Today what I'm going to try and do is give you a flavor for how we can use electronic health records and analyses done with them in order to provide better care. It's a very broad topic, and I'll give you a quick overview, and then we'll go deep into two examples, and happy to follow up in the Q&A session on any other specific topic. So in terms of overview, everything that I'm going to talk about begins with some data. And data could be in various forms, and these days you can, I'll give you a sampling. It could be medical records. That's what we're going to focus about today. That's at the about 10 o'clock position in this circle. There are reported data such as the adverse event reports that go to the FDA. There's clinical trials, chemical databases, health forums, news sources such as internet search logs that companies are increasingly trying to analyze for looking at health issues. You can also specialize and look at just physician search logs. There's, of course, published literature in Medline and PubMed, and so on. So data could mean a lot of things, and in at least one example today, we're going to span multiple data sets just to give you a flavor for what can be done by combining them. Then the other two tricks that are used in pretty much everything I'll talk about is this use of these things called ontologies. And for the purpose of this discussion, you can imagine them as directed acyclic graphs or tree structures of some sort. And this little cartoon, I have three of them. And whatever your entity of interest, such as a disease, melanoma or heart attack, the problem is that multiple medical ontologies or these graphs will have them. And it's quite challenging to figure out what kind of a thing a particular item is because different graphs give you different answers. And so there's a lot of work that goes on at Stanford in trying to combine all of these into one structure so that you can say heart attack and we will know the 49 different ways in which it could be written out in a medical record, and that sort of happens behind the scenes. And that's what's shown by this red circle, that you can refer to your object of interest using any phrase, and the system, the data mining system, would understand what you meant. And the other trick is the use of the actual hierarchical structure, that drugs and diseases have lots of different subtypes and alternative names. One extreme example, a simple molecule like acetoaminofen has 1,800 trade names. And you don't need to be a data mining expert to know that you don't want 1,800 different variants, and one would be better. And so that's the point of using these hierarchies to aggregate things so that when you're counting, you have less items you have more items and less features to worry about. So using data and these two things, these two tricks, we do a bunch of different things. We ask and answer clinical questions, and I have two examples up there. One of them is about trying to figure out are allergies associated with uveitis in kids with juvenile arthritis, and we'll go deep into that. The second big bucket is generating insights of the form, here's some data, tell me something new, tell me something I don't know. And then the last bucket, which we'll not get into today, is about predictive modeling. And of course, cost is something everybody cares about, and we have projects where we predict who is going to be expensive in terms of their care next year, who's not already expensive this year. Because otherwise, it's a pretty easy prediction. If you're expensive this year, you'll be expensive next year. And then specific predictions like delayed healing wounds. On the first week of care, we can predict who's going to be not healing by 16 weeks, and so that you can start taking advanced measures early on. So today we'll focus on just two examples, one on the clinical question side and the other on the insights, in the insights bucket. All right, so to give some background as to how activities in this area started over here on campus, this paper by Jennifer Frankowitz, Chris Longhurst, and Scott Sutherland came out in 2010, late 2010, in the New England Journal of Medicine. And the question that these doctors tried to answer was they were faced with having to treat a 13-year-old female with systemic lupus erythematosus. Now, systemic lupus is something that's typically not seen in kids. It's a disease that mostly affects middle-aged women, but they had to treat this 13-year-old. And there's nothing in the textbooks on how to treat such a condition, and they couldn't get a consensus amongst a few experts. So Jennifer queried the clinical data warehouse. Turns out that the hospital had seen 98 patients. No individual doctor had, but the hospital had seen 98 patients. And what she did was she started querying for the risk factors that they were concerned about. So in the leftmost column, you see the outcome thrombosis. In the second column, you see the words thrombus, thrombosis, blood clot. These are the three common ways you might write about them in the electronic medical record. And turns out that 10 out of those 98 patients had that. That's in the third column. And then for the different risk factors, which are shown as rows underneath the thrombosis row, she correspondingly used the appropriate keywords and got patient counts and then got the risk associated with having those risk factors. And as a result of this analysis, they chose to use thrombolytic therapy in this particular patient because that patient had high proteinuria, and which, as you can see, does confer a significantly increased risk of clotting. So when this paper came out, it caused a lot of controversy. There was questions about, is this the right thing to do? And it's a whole 1-hour talk by Chris Longhurst into all sorts of trouble they got into. But at the end of the day, the deans and the CEO of the hospitals and all of the senior people said, this is what people come to Stanford for. You want to use data to make the best decisions you can. And so we said, that was about the time I joined the faculty, and we said, how could we do this in a systematic way? So we started out building a system where you could imagine data in terms of this cartoon matrix that I'm showing you. And I'll show you exactly how we build it. But for now, let's say we had this, where each row is a patient or a person. Each column is a feature or a characteristic about them. Some drug that they have, some symptom, some disease, some procedure that was done to them, some device that was used in their treatment. And then the third axis is time. And if a particular individual was exposed to that drug or had that particular symptom, let's put a 1 in that matrix. If we know for sure that they did not have it, let's pretend we have a -1. And otherwise, we'll put a 0, as in we don't know. So if you had this matrix, the example that I just showed you was basically counting mentions of terms in this particular kind of a data structure, which you then group into concepts. So thrombus, thrombosis, blood clot all get grouped together into this variable that is clotting or having the outcome of thrombosis. Once you have your variables, of course, you can count. That's the easy part. And then you can do the association analysis to figure out what is what associates with the thing that you're concerned about. So then we actually built this kind of a system and did a new study. So the context for this is that kids with juvenile idiopathic arthritis have a risk of getting uveitis, which is an inflammation of the back chamber of the eye, the part behind the lens. And untreated uveitis can lead to blindness. And so the current guidelines of care say that the patients should be screened by seeing an ophthalmologist roughly about every 6 months. You take your child once and twice and 3 times and they're fine, and then real life hits and summer camps hit and nobody shows up the 4th time. And so a patient of a child with this condition actually posed this question to Jennifer Frankowitz, that could it be possible that allergies are associated with uveitis? So that's the question. And we said, all right, can we answer this? So we did this whole process, and then first we tested 4 known associations so that we could convince ourselves that we're not just seeing random noise here. So if your arthritis starts in less than 4 joints, which is what it means to be oligoarticular onset, that is known to increase your risk. Being positive for anti-nuclear antibodies increases your risk. Being positive for RF factor or rheumatoid factor is protective, and having a history or family history of psoriasis increases your risk. These are all known things. And so we reproduced them to convince ourselves that this kind of data mining is in fact possible. And then we tested the question that the parent of a patient had, And we are using allergies and allergy medications as surrogates for each other because the assumption being you wouldn't be taking an allergy med unless you have allergies. And turns out the answer that we were able to get out of the data mining is that yes, allergies are associated with the development of uveitis. Now, mind you, this is an association and can be used in many different ways. I mean, you could think of it as a finding that you need to then understand in terms of the science and figure out why is it the case. Or you can say, well, this could be confounded. It could be the fact that it is actually uveitis getting misdiagnosed as allergies and so on. But if all you're going to do is to prioritize who gets seen by an eye doctor, as in your intervention is scheduling an appointment via Outlook, you can just go ahead and start doing that because this is a way of sorting who is at increased risk of developing uveitis. And so if you wanted to do this at your own institution, this slide that I have sort of walks through the 4 big decisions that you would need to make. So CDW stands for Clinical Data Warehouse. And if you have a clinical data warehouse, how do you get to that patient feature matrix, which I had on the left-hand side on the previous slide? So the picture in front of you is just the green wiggly line showing the amount of data of different kinds that have accumulated over the years in the Stanford Clinical Data Warehouse. So if you want to go from that to this patient feature matrix, there's 4 decisions to make. What ontologies are you going to believe for drugs, diseases, devices, procedures? Then how are you going to map them to one another? How are you going to figure out that heart attack can be written out in 49 different ways, or that catheter is a device for catheterization? Then how are you going to walk up and down the hierarchy? At what level will you choose to ask your question? Would you ask your question at the level of a beta blocker or anti-allergy medications or whatever is the drug type of your choice? Or would you ask the question at the level of a particular drug like atenolol in the example of a beta blocker? And then the 4th question is, at what level do you stop? Because at the lowest level, you are very precise, but you have very few patients corresponding to that particular item. And at the root node, you have drugs, disease, procedures, device, which is not that useful. And figuring out the right level is an important question, important decision to make in the analysis. So to make this, these 4 decisions, the way we approach them is to start out with lots of unstructured data. What you're seeing is a screenshot of a fake clinical document. That input text goes into a text processing engine, which reads in its processing something we call a knowledge graph, which corresponds to the correspondence between the different kinds of entities you can have and so on. Along with that, you feed in some ways of detecting negation, because a lot of medical writing involves things like no evidence of hypertension or no sign of so and so. In the knowledge graph, not only do you get the correspondence between things and the hierarchy, we also have a lot of additional information of the form, how often is a particular term, such as acute myocardial infarction, the whole thing mentioned across the records of millions of people? So think of that as some version of term frequency and inverse document frequency. We also calculate how often is a particular phrase a noun, or an adjective, or an adverb, and so on. And most diseases I know of are nouns. And so if your particular text phrase you're looking at is not a noun, you don't have to worry about it being a disease for the most part. And then the third thing we do is we ask how crazy or confusing a term is. So something like cell, C-E-L-L, is very confusing because it could mean a cell phone, it could mean a terrorist cell, it could mean the cell in a petri dish. We try to avoid those kinds of terms. But something like acute myocardial infarction is kind of straightforward. It only means one thing. It couldn't be somebody's name. And so all of this goes in, and out comes an index where what's really stored is just the blue portion, which is just a bunch of integers and numbers. And the other portion is just a human-readable visual. And the main take-home is that everything that is not a medical thing becomes white space. Only medical words are preserved. and the things that were negated are shown in red. So that's sort of the takeaway from that picture. And then what we avoid is that at this analysis, this processing time, we do not try to bind the term to a concept. And what I mean by that is if I see stroke, S-T-R-O-K-E, we don't try to determine at the indexing time that is it heat stroke, heart stroke, or cerebrovascular stroke, or stroke of luck, or the bird that brought the baby, or what have you, because that's hard. That's what clinical NLP tries to do. Instead, we say we will defer that decision till we absolutely need to make that determination. And there's some advantages of doing that because when at analysis time, in the 500 patients or 1,000 patients you're looking at, if you see ice packs, all of them were admitted in August and they're all under age 18, well, it's heat stroke. You don't have to worry about the other interpretations of that. So you can use other dimensions of information to decide what that particular term means. And all of this is then stored in an index where you can think of it as each row being an individual, each column is a term, not yet a concept, and then we're just storing was it mentioned, not mentioned, was it negated, and so on. And then when you have a question, we would then take your phrase of interest, go to that knowledge graph, expand it out into all the possible interpretations, what could it co-occur with, and so on. And using that, go to this index, and that's what allows us to count the present positive mentions of things, keeping track of the negation, keeping track of the history and the family history, and that's what gets us the patient feature matrix that we would use in this kind of analysis. So this was a very technical slide, but just to give you a flavor for how the things happen under the hood. And this particular step, the second step, if we actually did it for juvenile idiopathic arthritis and the uveitis and things like that, which I mentioned in that example, what would happen is you would get this list of ICD-9 codes, you would get this list of terms. In case of allergy medications, it would expand into things like Flonase, Nasacort, Allegra, Zyrtec, and all of those things that we would then go look for in the unstructured documents, the clinical documents. All right, so we did this, and we did a couple of other projects. And then we sort of said to ourselves that, this problem of a doctor having to figure out what's the right thing to do is a pretty common one. And it might come to you as a surprise, but a lot of medical care is educated guesses. And even in a well-studied field like cardiology, only 19 to 20% of their practice guidelines are based on randomized controlled trials. And that's cardiology, which is so well studied. And if you ask a practicing clinician that how many times is a clinical practice guideline applicable when they're seeing a real patient, someone who doesn't have just heart disease but also has diabetes and hypertension and other things, very rarely you get an answer above 20%. And so if 20% of the care is based on randomized controlled trials and it's applicable to 20% of your patients, well, back of the envelope math, about 4% of the time you have a textbook case, quote unquote. And the other time you're trying to reconcile evidence that is generated from patients that are not exactly like the one in front of you, but you're trying to reconcile 3, 4 different alternative guidelines. And so the opportunity is to make decisions based on what happened to real people like you. And so the cartoon that I show over here is that you can imagine describing a patient, in this case a 55-year-old female of Vietnamese heritage, has no asthma, presents to her doctor with new onset hypertension. Now, you don't need clinical decision support to help the doctor and understand what the problem is. They've gone to school for 10 years, and I bet they can diagnose hypertension, no problem there. And then the outcome is also pretty clear, that you want to get the blood pressure to be under 90. Wikipedia could tell you that. The question is which intervention to use, which antihypertensive to use. And there's no clinical guideline that's available because nobody tested Vietnamese heritage women in terms of their drug response, and definitely not ones with asthma. So could we just go to the data and compare that of the 2 or 3 drugs that you're considering, what is the median time to event? So the blue dashed line and the green line are just showing the percentage of people whose blood pressure was still not under control that many months after initiation of therapy. And in this cartoon example, drug A seems to be better because in about 4 months, as people start responding, more people start responding to that drug. The second thing you might want to know is what else associates with the outcome. Are there other things that are just confounding and are giving you spurious results? And then finally, you would want to know that what is the underlying set of people based on which you're actually making these determinations. And so we generalize this idea into this concept, which we call the green button. And this is an actual URL. If you go there, you'll see this pretty much this exact same slide and some more explanation and a link to a paper. And the notion here is to personalize evidence. So people talk about personalized medicine all the time, and typically it's interpreted as we'll analyze your genome and figure out what drug may or may not work for you. But I would argue that it's possible to personalize even before that. I mean, we can start using the experiences of other people who are similar to you. And of course, it's kind of hard to define similarity and so on, and there's lots of research in that front. But if you have a clinical situation, you have a patient in front of you, there's a practice guideline based on an RCT, by all means go ahead and use that. That's the orange diamond and then the orange box on the right-hand side. But if you don't, then press this thing, which we're calling the green button, build a cohort of similar patients. If you have it, great, use practice-based evidence. Otherwise, keep doing what you were going to do anyway. The advantage is that as a byproduct of this, we get a priority list of clinical situations where there is true ambiguity. It's a data-driven way to figure out in what situations do we not know what to do. And these are the things you can then prioritize for randomization at the point of care or do a future study to figure it out. And so we outlined this idea in a paper called a green button for using aggregate patient data at the point of care, and that's why the previous URL is greenbutton.stanford.edu. And so the main take-home here is that this idea gets you patients like mine. And you can use that. You can use the patterns and trends you see in similar patients for a lot of different things. So this little table is showing you the different rows are the different use cases of what you could do with a set of similar patients. The first row is you could use that for prognosis. And the output could be just simple raw counts. That's what Jennifer Frankowitz used in 2010. Or you can have an association report, which is what I showed you a little mock-up of 2-3 slides ago, which just shows you the effect size and the time to effect and what's the underlying cohort and so on. You can use the output to support an intervention, and I actually showed you an example of that, the Uveitis example. You can use that to figure out who should see their eye doctor and schedule an eye appointment. You don't need FDA approval for that. And then you can use it for other operational things, such as examining outcomes that are related to the quality of care. And I'll actually show you one example of that around DVT rates and urinary incontinence. And I would sort of point out that inferring causality is one thing you could do, but it's kind of hard, and it's a bit premature to jump to those kinds of conclusions. But there's a lot of other things that can be done without figuring out causality. And that's sort of the take-home of this slide, that if you're able to build a set of patients like mine, you can still start doing things that provide better care without actually figuring out what the underlying scientific causal association is. All right, so here's the next example on the operations of medicine side, and mostly based on quality metrics. So one of the quality metrics that's monitored quite often is the rate of deep vein thrombosis after undergoing a particular kind of surgery, say vascular surgery. And people look at 30-day DVT rates. And so the plot that I'm showing you here, on the x-axis is time in 10-day increments, and then on the y-axis you have the frequency or the number of people who had a mention of DVT events in their record that many days after surgery. And it's kind of hard to see, but about a third of the event mentions are after 30 days. So if you're looking at quality of care, you better look at those mentions that are outside of your 30-day window. Another example is the rate of urinary incontinence after prostate cancer surgery. For men undergoing prostate cancer surgery, there's only two real questions. I mean, are they going to leak and are they going to be impotent? And these things are not coded or captured in the billing codes because a hospital or a doctor doesn't get paid more for seeing a leaking patient. But you can be sure that if someone is incontinent, they will tell their doctor. And there's only a few ways to misspell incontinence, so you can count that pretty easily in the data. And what you're seeing on the left-hand side is counting the rate of urinary incontinence using coded data, and the right-hand side counting the same thing using textual documents. And these are questions that are or outcomes that patients really care about. And it does matter when choosing, would you want to undergo robotic prostate surgery or would you want to undergo open prostatectomy? These rates could be different between those two kinds of surgery. One surgery, the robotic one, is 3 times as expensive, and before making a decision, most people would want to know. So there are these kinds of operational things focused on quality metrics that can also be done using data on similar patients. And then actually I'm going to skip over this example and jump into the next one, which is about generating insights. That's sort of the next bucket where you have this pile of data and the goal is to learn something new. And the thing that I skipped over is just doing that same kind of text processing to figure out that in patients who undergo chemotherapy, who comes back to the ED in an unplanned fashion and for what reason. So that's sort of the gist of that slide, and we're able to figure that out just by looking into the ED visit notes and telephone encounter logs and so on. All right, so let's go into the insights portion. So let's, same idea. We have a whole bunch of textual documents, about 10 million of them. Push them through that data analysis pipeline, get the patient feature matrix. Each row is a patient, column is a medical concept, and then start counting some very simple things, such as how many people got diagnosed with rheumatoid arthritis, then were prescribed Vioxx, and then got their first ever mention of a heart attack. And then you can have all of the alternative patterns that you have a heart attack before you ever had arthritis, or you got arthritis, you had a heart attack, the Vioxx came after that, or you had arthritis, you took Vioxx, nothing happened, or you got a heart attack without ever touching Vioxx or being prescribed Vioxx. So there's about 29 different patterns if you have 3 things and you allow for before, after, and at the same time. So 20, 30 minutes to enumerate them, and then a couple of months to argue where you're going to put them in this 2x2 table. And at the end of the day, once you're done with those decisions, you can make these kinds of plots. So the x-axis on this plot is calendar year. The y-axis on the left-hand side, the ROR, is the reporting odds ratio, which just is the association between the mentions of Vioxx and occurrence of myocardial infarction after being diagnosed with rheumatoid arthritis. And the solid red line is tracking that association. The dotted lines are the error bars. The green line is just tracking the number of people who are exposed to that drug, and the y-axis shows you, on the right-hand side, shows you the drug exposure. So if you look on the x-axis at 2005 and then just go straight up, the green line becomes flat, so that's nice. That's when the drug was actually recalled. But if you see that around 2003 is when the lower bound of the red line, the dotted red line, was above 1. And so if this was a data mining system, that's when we would have sort of suspected that, okay, maybe something's going on and we should investigate this drug more often. And this is the kind of data analysis actually that Kaiser did many years ago, which ultimately led to the 2005 recall. Turns out that this simple analysis done using text mining could detect 6 out of 9 recalls in the past decade. And if you're a computer scientist or informatics person, you can say, well, you can get 9 out of 9 if all you were doing is saying yes. And so we said, fine, we will go ahead and make a gold standard of 28 positive test cases, 165 negatives, 12 events, and 78 different drugs, and we made this thing which is called a receiver operator curve, which shows you the trade-off between getting a true positive and getting a false positive. And the blue and the red lines are basically analyses done in two slightly different ways. In the analyses done corresponding to the red line, we're matching people based on how sick they are, and yes, that does improve the ability of discriminating true associations from false ones. And you can see the AUC is is about 80%. Turns out this kind of performance is within range of what you would be able to do with the spontaneous reports submitted to the FDA. So something to think about, that if you have lots of EHR data, you can run a data mining system at your hospital, at your facility, that is monitoring for drug safety associations, and it would be about the same effective as relying on spontaneous reports. Now, of course, this is all cutting-edge stuff. This is research. This came out about 2 years ago, and since then we've been collaborating with the FDA to figure out how could this scale to multiple sites and how could we make this into a robust, validated system. All right, so when we did that data mining study, one of the things that was flagged as a possible positive was an association between proton pump inhibitors and myocardial infarction. And so that's what led us to investigate proton pump inhibitor safety. Now, it turns out other faculty here, John Cook, who was here at that point, and Nicholas Leeper, were already studying these drugs in collaboration with Johannes Gebremariam, who's now at Houston Methodist Hospital. And they were screening molecules that inhibit this enzyme, DDAH. DDAH breaks down this red thing, which is acyclic dimethylarginine, into citrulline. Because if ADMA accumulates, it inhibits nitric oxide synthase, and you get less nitric oxide in your blood vessels. And a 10% increase in ADMA, this red box, is known to associate with bad cardiovascular events. And so in their high-throughput screen, they found that proton pump inhibitor drugs bound to this enzyme, this green enzyme, and knocked out its activity. So as you can see in this cartoon, if this green stuff is not working, the red stuff is going to accumulate, and when that red stuff accumulates, you'll have less nitric oxide in your blood vessels. Okay, so now we have some experimental evidence that these drugs, proton pump inhibitors, have a plausible mechanism of damaging the lining, the endothelium of your blood vessels. And we have this separate data mining study where we have a way of asking for an association between a drug and an adverse event. Put the two together, and we were seeing plots like this. This particular one, I think, is pantoprazole or lansoprazole, and x-axis is still calendar year, y-axis is the strength of association as we pick up according to that data mining process that I told you. The validation is based on that set of 28 positives and 165 negatives. We were able to pick up 17 of the 28 positives, so sensitivity is 61%. We only got 4 false positives out of the 165 negative ones, so the false positive rate is low, 2.5 to 3%. And then when we saw this, we said, okay, we're going to look at these drugs, proton pump inhibitors, in younger people. So that's the third blue bar. And these are people who are not at risk of cardiovascular events from other causes. We also looked at the alternative drugs for which the PPIs are used for, which is for acid reflux, and that those drugs are called H2 blockers, and we did not see an association. And all of this is still done using the Stanford data, which has about 70,000 patients. We then collaborated with Practice Fusion, a company up in San Francisco. I don't have any affiliation with them. They just were kind enough to let me use their data. And we see that these associations between taking proton pump inhibitors for acid reflux is seen even in their data set, in 227,000 people. And here's the kicker. We then broke down the proton pump inhibitor. Remember the drug hierarchies where you could ask the question at the level of the class of the drug and then break it down into the individual drug? So that's what we're going to do. Now we break it down by the individual drug, and so instead of just the proton pump inhibitor class, now we're looking at omeprazole, lansoprazole, pantoprazole, rabeprazole separately. And we can see that different drugs have a slightly different association strength. Turns out that this association strength actually mirrors the ability of those drugs to inhibit that green enzyme. So the stronger the inhibition, the stronger the association, roughly speaking. It's not a one-to-one correspondence. And so taken together, now that we have experimental results, we have a data mining result, turns out that these drugs have already been under a cloud because they're frequently prescribed to people who've had a heart attack and then are taking Plavix or clopidogrel, and that gives them stomach acid, and therefore these get added to that prescription. And then there's argument about, well, is it actually the proton pump inhibitor that's causing an increased risk of heart attacks, or is it that these people were already at a risk of a heart attack, or that these drugs are interacting with clopidogrel in some way? And there's numerous papers sort of figuring out and arguing what is the true situation here. What we found is that we see this association in people with acid reflux who are not at risk of a heart attack just because for any other reason. And we have a plausible experimental mechanism. Taken these two things together, we believe this is something that's worth investigating. I wouldn't want to start a panic attack and saying, let's not take these drugs at all. There's some media coverage that would want to make you believe that that is the case, but the real science is slightly different. And then the last thing we did was we looked in a prospective cohort. It's a small cohort, about 1,500 people, and the question we asked is those people who use proton pump inhibitors, what is their 5-year survival overall? And turns out they have a lower 5-year survival. This plot translates to a hazard ratio of about 2. And so this is a third source that is signaling that there may be something going on here. So all of this taken together, do you think there is cause for further investigation? I'm really interested in hearing the audience response here. It's a simple yes, no, so you can only be wrong half the time. Okay, so that is basically the conclusion in our paper, that taken together, there is cause for further investigation. But if you see the press coverage on this, it ranges from breathless headlines that say heartburn drugs cause heart attacks to all sorts of different things. All right, so I think in this audience, at least people have sort of gotten the gist of it, that you can use multiple sources of data to prioritize what is worth investigating. So then, as an individual, if this was the science you saw, what would you do? Would you stop taking the drug? Would you switch to alternative, or would you wait and watch and see how the science unfolds? All right, so I see that about half the people did not answer this one. Most of you answered the previous one, and some of you would stop, some of you would switch, and very few, okay, the least number of people would stop, so that's good. At least there's not mass hysteria. And a good fraction would wait and watch, and the other people would play it safe, and so let's just switch till everybody figures this out. So the point of these questions is that interpreting science for public consumption is hard. And you can see in your own responses that there's no easy answer, and almost half of you chose not to answer this one. All right, so my summary on this is that data mining signals or provides a hypothesis about an association in 2 separate data sets. Survival analysis on another small data set shows an association. We have a plausible mechanism. Given all the other studies and the potential for the population level impact, yep, I agree this is worth studying further. And so that's sort of all I had in terms of the 2 examples, and this takes a lot of people to do this kind of research. So my group is about 16, 17 people, keeps fluctuating. The collaborators I mentioned, Nicholas Leeper, John Cook, and Johannes, who did the experimental work, and funding from lots of different sources, NIH, fellowships, industry funding as well, that keeps our group and the research going. So that's the acknowledgements, and I'll end here. Okay, thank you. So there's a bunch of questions, and let's see. I'm going to lump them into buckets in order to answer the more questions than to go them one by one. one of the questions or the bucket of questions is, are they all univariate associations or multivariate associations? These are all multivariate associations. That's an easy one. There's a bucket of questions around irrelevant information, noise, and getting fooled by data mining. That is definitely a danger in these kinds of research, so you have to validate. And it is still new. None of these systems are implemented yet, and I would still call them at research stage. There are questions about moving towards real automated decision-making for prescribing. I would say that's jumping too far ahead. I wouldn't want it to be automated in terms of the computer just adds an order to my prescription. Rather, when someone is making an order, I would want to know that when this action was done to others, what happened to them. So that's the stage at least where we're at. There's questions about what analytic tools we're using to do this kind of data mining. This is an academic shop, so it's mostly open source software, R, using MySQL for storing things and then pushing as much things into memory using machines with terabytes of RAM rather than trying to deal with complicated data mining systems. Because with students and postdocs, we just don't have sort of the software engineering expertise necessary to use the products for data mining that are out there. Let's see, how can this data-driven approach be scaled? That's a great question. If you have suggestions on how to scale this, I would definitely want to know. Right now, there's still a manual component involved because at the stage where you're defining your outcome of interest, we still need to review the terms and the codes and things that we are going to be counting on, and it's not fully automated yet. All right, so more questions. Do you need a hypothesis to find associations? It seems it's easier to find them after the fact once they've been unveiled through other mechanisms. So in the example that I showed you, that might have led to sort of given the impression that you always need a hypothesis. If you have a hypothesis, your confidence in the result is definitely much better. If you're doing it in pure discovery mode, which we have done, to say find off-label uses, then you have to factor in the fact that even with a highly specific system, even 99% accuracy and just say 99% specificity, 1% false positive rate, if you test 2 million things, you're going to end up with 20,000 false associations. So you can't ignore the math here. And so doing blind data mining is not something that I would want you to take away from this this conversation. Then there's a question, the translational science, how would you get 10% of your stuff applied to the majority of medical centers? As you know, most are intimidated by the workings of what you propose. I know the person who asked this question, absolutely right. Yes, this is scary for most hospitals. Most hospitals don't even have the environment for doing data mining, so that's why this is still research. I don't have a good guesstimate on how to get this deployed and by when across many health systems, but at least Stanford is pretty supportive of the work here. There's questions about perception and cloud security. I don't have a strong opinion on this because most of the stuff that we're doing is not really cloud-based, but my sort of consumer level opinion on this is that when we trust our credit card data to the cloud and we swipe it out at any opportunity to buy a sandwich or to buy a coffee, not knowing who the person is and what terminal is it swiped into. So I would be more concerned about financial data than health data, but that's just me. It's not the official opinion of Stanford. Then are you working with the FDA to access the data? I'm not working with the FDA to access the data. The data is at Stanford, but I am working with the FDA to validate these methods further to make sure that we're not seeing just random noise and to develop ways of bringing EHR data mining into the FDA surveillance mechanism. But again, all of those are research collaborations. I don't have any products to sell or anything of that sort. Where are the data from? This is mostly U.S. data. How the course is going to help for a pure technologist, but without any background in medical domain. Will there be any job opportunities after the course? Well, I can't comment on the job opportunities, but what I can say is that if you're able to do data mining on health data, there's tons of opportunities in the Bay Area, but I don't think I would be qualified to name any specifics there. For the data discovery use case, what control did you consider for controlling false positives? That's the true positives and the true negatives I mentioned. We had the 28 positive cases and 165 negatives. Using that gold standard, we sort of got a handle on our false positive rate. Would you say that learning R and RStudio is crucial when taking a graduate certificate, like mining massive data sets at Stanford? Yes, that's the easy one. There's questions about what if you have all the patient's genomic data? Well, I would point you to the the big biomedical data science initiative, where the idea is to scale this beyond just EHR mining. And EHR mining is something that I do in my group. There are other faculty who are doing amazing things with mining genomic data, metabolomic data, proteomic data, and of course we would like to put all of this together. But not in the context of just one faculty member's group.
Okay, thank you so much, Nigam, for answering the questions, and to all the participants for submitting such thought-provoking questions. We really appreciate it. And finally, we would just like to, on behalf of the Stanford Center for Professional Development, thank you for joining us today for our first webinar in the Big Data series. Thank you so much. Enjoy the rest of your day.